Okay. So, what may be the steps of diagnosis of hypertensive disorders in pregnancy? Always the first step is history taking. And on history taking, usually we do it on antenatal or the first antenatal visit. So the personal history, especially the age, we are saying that pre-eclampsia is very common in young prime gravidas and also in elderly prime gravidas of about 35 years and above. So usually we take the family history and we ask about the chronic diseases like hypertension, diabetes, epilepsy, asthma, etc. And on family history, we shall have a positive hypertensive history, either from the parent, either mother or father. So this woman will report a positive family history. Then we also take the medical history, asking this mother whether she has had any of the chronic medical conditions, among which hypertension can be very key. So this mother may give us a positive history of being hypertensive even before pregnancy. She may even report other conditions like kidney diseases. Remember, kidney diseases predispose a patient to hypertension. Then heart diseases, diabetic diseases also, they predispose to hypertension. So when a mother reports any of these chronic medical conditions, we must take note of it. Then we go ahead to ask about the past obstetrical history and whether this mother have ever had pre-eclampsia on previous pregnancies. Remember, this mother may be normotensive or this mother may be hypertensive at around 20 weeks, but we say that gestational hypertension usually resolves after 3 months of puerperia. So as we are taking the past obstetrical history, this mother can give us that history that on the previous pregnancy, I developed hypertension and I was put on drugs, but after I delivered, everything went back to normal. So we just not take it for granted. We can start thinking about a second predisposition of hypertensive disorders on this present pregnancy. Then again, we shall ask about the present complaints. Remember, we said in pre-eclampsia, the mother will, in severe pre-eclampsia, the mother will start complaining of headache, blood vision, epigastric pain. So we ask about those present complaints. And if the mother reports about headache, if the mother reports about blood vision, severe epigastric pain, swelling of the feet, then we can start to think about hypertensive disorders in pregnancy. So after our subjective data, we go on to do our objective data. Of course, we take the blood pressure as a routine on every antenatal visit, and this time we shall have a BP equal or over than 140 over 90 millimeters of mercury. And if we get it at first take, we shall request this mother to have a rest. And after around 4 hours, we can repeat to take the blood pressure. And if it is still persistently high, then we start thinking about hypertensive disorders. Then we go ahead to do examination, that is head to toe. First of all, we must confirm pregnancy, whether this mother is pregnant, and also look for signs of edema. And here, there are key sites whereby we can look at edema. Remember, during abdominal examination, we do auscultation as one of our last steps, listening to the fetal heart. But After putting a fetoscope and removing it, it may leave a marked sign which shows edema on the abdomen. So we don't let it just for granted. Then this mother may report with a perfect face, and as you look at the mother, or the face is perfect, you check on the ankle and the tibia. All these are signs and sites of edema, which is suggestive of hypertensive disorders in pregnancy. And this mother will always report that even if she rests, this edema is not subsiding. So this edema is slightly different from that edema of renal and cardiac diseases, because the others subside on rest. But edema due to hypertensive disorders will never even subside on rest. So if we see this, we go ahead to order for some investigation. And the key investigation we shall order to is a urine testing. And as we do a urine testing, we shall have protein in urine which is greater than 5 grams in 24 hours of urine apart, or 3 plus, or greater than 2 random urine specimens collected at least 4 hours apart. So when we order for that, we shall start suspecting. Okay, so after taking all those diagnostic steps, that is history taking, observation, examination, and investigation, then at this time we've come up with a diagnosis, either eclampsia or pregnancy-induced hypertension or chronic hypertension. But remember, chronic hypertension, this mother is having drugs she's on, so we can evaluate her drugs and how they respond to her treatment. And if this mother is getting gestational hypertension without signs of pre-eclampsia, these mothers can be started on oral hypertensive drugs. Preferably, methyl-dopa is said to be safe in pregnancy. But if this mother is having signs and symptoms which may detect pre-eclampsia, we just know that this mother and the fetus are at risk. So prompt management is going to be done. And here our main aim is to minimize both maternal and fetal risks associated to hypertension. And if this pregnancy is at term, the decision is easy. The baby should be delivered. The decision to deliver involves balancing the risks of worsening pre-eclampsia against those of prematurity. So here we said that pre-eclampsia predisposes this mother to multi-organ end failure. That is the kidney, the heart, the brain, the liver, etc. So now here we weigh if we would like the mother to go home with multi-organ system failure or with a premature baby. We weigh the two, and preferably we think that saving the mother is better than having a premature baby. So if this baby is real premature, usually, and this mother is in a very poor state or in a hypertensive crisis, this is an indication of what we call a therapeutic abortion. We shall induce labor and this baby will be delivered. If the baby is past 28 weeks of gestation and the baby can survive extrauterine, again, delivery methods can be thought of depending on obstetric examination, whether this mother can push the baby or whether there are some obstetric contraindications like transverse lies, cephalopelvic disproportions, small pelvis, whereby this mother can be taken to theater and the baby removed as a premature. and then we manage a premature baby. Or if this baby is term, that is past 37 weeks to 38, we shall induce labor if there is no any obstetric indication to vaginal delivery. We shall induce the mother and then have the baby. So we have said that pre-eclampsia is characterized by signs of hypertensive crisis. That is BP of above 160 over 110. But then there is that what we call severe pre-eclampsia. It means this mother, her prognosis is very bad and her condition is worsening. So when we say severe pre-eclampsia, it is characterized as mild or severe based on the degrees of hypertension and protein in urine and the presence of symptoms resulting from involvement of the kidneys, brain, liver, and cardiovascular system. We've talked about signs like severe headache, visual disturbances, and epigastric pain. These signs are a signal to impending eclampsia. If a mother reports having a very severe headache, the mother is saying, I'm not seeing, or I'm seeing two people walking, I'm having a very severe epigastric pain, then that is a sign that any time this mother is going to convulse. And convulsing, it means the brain is now affected. So increased peripheral vascular resistance and pulmonary edema may occur. Here we have a decreased glomerular filtration rate, which may progress to oliguria, and then from oliguria we can go to acute renal failure. So during all our management, we should aim at preventing this mother with hypertension to progress to eclampsia, severe pre-eclampsia, and then end organ damage. Otherwise, after this mother has had organ damage, we may end up losing the mother. So all our aim looks at early detection and prompt management of hypertensive disorders.